Good evening, friends. Today's topic is assessment of reperfusion post thrombolysis or primary PCI. See, this is not an important topic for MCQ point of view, but it is clinically most important. Most of the emergency setup we are thrombolizing the case. Okay, and at the end of the day, we just want to know whether you have successfully thrombolized the case or not. Okay, how to assess? See, the most important thing is prompt resolution of the pain. So when there is sudden decrease in pain after thrombolysis, okay, it is a very good sign. It is a very good sign. And coming to pain, the pain perception is a subjective. Okay, so for some patient, mild lingering pain, it may be normal. Okay, and if you have a patient of diabetic, okay, he won't get any sort of pain. Okay, MI can present without pain also. And for example, in other cases like cardiac transplant patient, he won't get any kind of pain due to neuropathy. And coming to analgesic for pain, generally what we are using analgesic for pain is morphine, fentanyl, midazolam. So the important thing is, remember here is injection fortwin. Injection fortwin is contraindicated in acute MI. Fortwin is pentazocine. Okay. Then one more thing is pericarditis. Pericarditis pain may persist. Okay, so this is all about pain. The important thing is sudden decrease in pain after thrombolysis is a good sign. That's it. And second thing is achievement of electrical and hemodynamic stability in a patient who is previously hemodynamically unstable. Okay, that means before thrombolysis a patient is unstable, hemodynamically unstable. That means he may be having hypotension as well as electrically instability, means VTR, any kind of arrhythmias. After thrombolizing, if he is hemodynamically stable and achievement of electrical stability is also a good sign of perfusion. Okay, and the most important thing is the electrical instability is not depends upon the size of the occluded vessels. That means if the left to main coronary artery, that means, okay, suppose if you have this is LMCA, imagine this LMCA, left main coronary artery occlusion is there. This occlusion doesn't produce massive electrical instability. That point you should know. Okay, so opposite to this is even a small area of occlusion may produce electrical instability. Okay, a small artery occlusion may present with VTR VFib. So basically this is not small, this is small. Small artery occlusion may present with VTR VFib. And the most important thing is STR. What is STR? Is ST resolution. ST resolution means before thrombolysis you have ST segment elevations like this. Okay, and after thrombolysis after PCI intervention, if the ST segment level come to baseline, okay, comes to baseline, so it is called ST resolution. So complete ST resolution means there is more than 70% of the ST segment elevation should come down. So it indicates TME3 blood flow and MPG3 blood flow. So what is TME3 flow? We'll see later. And partial ST resolution is if you are getting ST segment depression of 30 to 70%. If you are getting, it is partial. If the ST resolution is less than 30%, then it is none. That means your thrombolysis has no value. Okay, and then how do you calculate ST segment elevation? See, so here you have one method and two method. One method is, which is most commonly used, is sum of all ST segment elevation before and after thrombolysis. That means if you have ST segment elevation in V2, V3, V4, V5, okay, so you should calculate individually. Like suppose in V1 you have ST segment elevation of 4, in V4 in V3 here you have 4, you have 4, you have 4. Sum of its total is totally 16 small boxes. Okay, 16 small boxes. It is before thrombolysis. After thrombolysis, this should come down. Okay, in this way. So it is the most common method. And the other method is you can calculate a single lead which has a maximum ST segment elevation. Suppose in V2, V3, V4, V6 for example, if you are getting massive ST segment elevation like 5 small boxes elevation at VT, we are considering this lead only. So single lead maximum ST elevation we should consider. So in this image, okay, complete resolution is more than 70%, partial resolution is 30 to 70%, and less than 30 is none. Okay, this is how do you measure. So this is a baseline. You can see this 1, 2, 3, 4. You can see the four small boxes here. So after reperfusion, there is ST resolution of more than 70% here. Okay, it is a successful thrombolysis. Where here it is not up to level. Okay, so it is no proper reperfusion in this case. And here you can see a journal like it is an article. See, extent of ST segment resolution, extent of STR after fibrinolysis adds improved risk stratification to clinical risk score for ST segment elevation at MI. And then what is TIMI flow? Okay, after MI you are performing a coronary angiogram. Okay, in that you have TIMI 0, 1, 2, 3. TIMI 3 flow means this is normal flow. That means the flow is completely normal. It is TIMI 3. It is called as TIMI 3 flow. So this is our target basically. If you are getting 0 means there is complete occlusion, that is 0. Okay, and TIMI 1 is penetration of obstruction by contrast but no distal perfusion, that is TIMI 1. And TIMI 2 is perfusion of entire artery but delayed flow. In TIMI 2 and TIMI 3 is the perfusion of the entire artery is there, but in TIMI 2 you are getting delayed flow. In TIMI 3 there is normal flow. It is the difference here. So what is your target is TIMI 3. So in this you can see that. So this is the mortality rate here. So TIMI 3 is a normal flow which indicate only 4.7% of mortality. So higher the occlusion here, complete occlusion, higher the mortality here. Then comes the question, how do you calculate STR? And when do you take a post lysis ECG, and what percentage of STR constitutes successful lysis and what is failed lysis? We'll see all together. As we know how do you calculate the STR. Then when do you take post lysis ECG? Now here comes the question. When do you take post lysis ECG? So these are the options given. So actually as per standard book, as per standard guidelines, the answer is 60 to 90 minutes post thrombolysis. So here answer is 60 minutes and 90 minutes. Both are correct. Okay. So it's all depend on your institution where you are working. If you are taking ECG after 60 minutes, you follow these guidelines. If you are taking ECG after 90 minutes, you follow this guideline. It's all depend on institute. We usually take a ECG of 90 minutes. So that is after 1.5 hours. After 1.5 hours. This is where I used to work basically. This is STR. Okay. So more than 70% successful thrombolysis. So more than 70%, less than 50%. Less than 50% is failed thrombolysis. Do rescue PCI immediately. If you are getting more than 70% successful thrombolysis, I mean more than 70% of ST resolution is there, that means early PCI pharmacoinvasive strategy 2 to 24 hours later you can go for PCI. Then coming to the next thing is T-wave inversion, how it is important. See, the most important thing is T-wave inversion. Immediate T-wave inversion is a very good sign. That is less than 4 hours. If you are getting T-wave inversion, it is a very good perfusion. If you are getting after 4 hours, it is not a good sign. Okay, and without any intervention, end of the day you will get T-wave inversion. Okay, so it means a post MI case invariably, whether you thrombolyze or not, end of the day ECG you will get is T-wave inversions. But if you want to look for reperfusion, immediate T-wave inversion that is less than 4 hours has a robust indication of successful perfusion. This is what important. Coming to cardiac enzymes, as per latest guidelines, there is no role of CPK-MV. So you have got a acute MI case where ST elevation is there, and you want to check CPKMB levels 0 hours, okay, after 6 hours, after 12 hours. So this is your CKMB first report, this is your CPKMB second report, this is your CPKMB third report. So basically in acute MI, what happens is after 6 hours your CPK level, CPKMB level will shoot up. But if you have done a good procedure, if you have done a successful thrombolysis, okay, the reperfusion it will indicate a rise in CPK level as early as possible. It is a early peaking of the CPKMB2 is a good sign for reperfusion. And remember, as per latest guideline, we are not using these enzyme levels. So it is one ECG. Here the answer is no management. Earlier the answer is it is a specific marker of reperfusion. So basically it is AIVR. So this kind of arrhythmias, earlier it is a specific marker of reperfusion, okay, but nowadays we are not considering AIVR kind of arrhythmias as a signs of good perfusion. See, look at this question. AIVR is no more a sign of reperfusion arrhythmia. Earlier it was considered as a sign of perfusion. Remember, practically AIVR is a sign of reperfusion arrhythmia, but for exam point of view, for your exam purpose, don't consider it as a reperfusion, don't consider it as a sign of reperfusion arrhythmia. That means post lysis, if you are getting AIVR, what you should do is, answer is no management here. Earlier answer was basically it is a specific marker for reperfusion. It is a kind of arrhythmia what you are getting. Now this is one of the important thing. So these are also marker of reperfusion, but these are not that important basically. If you are getting sinus bradycardia with hypotension, it is a good sign. If you are getting late diastolic VPC, it is also a good sign. If you are getting two-fold increase in VPCs, it is a good sign, okay. And earlier if you are getting AFib and VPB pattern, and later it will disappear after thrombolysis, it is a good sign basically. So these signs together are also suggestive of reperfusion, good reperfusion. Now comes the question, among all this, which is the best sign of reperfusion? So the most important thing is pain subside. That means it is a good reperfusion. And from unstable case to hemodynamical stability and electrical stability you are getting, that means it is a sign of reperfusion. And STR elevation more than 70% is a sign of reperfusion. You should remember at least these 3 points. So there ends the topic. Okay, right.